Okay, good morning, everybody. What a morning. I remember last year that was my first global symposium in Florida. I was sitting right there. And now the time and the position has changed, and I can stand up on this podium in front of many friends and colleagues, and I can present from my favorite topic, which is a little bit complex. We have to deal with soft tissue, with GBR, with proper implant positioning, and of course, we have to deal with the prosthetics. So as Maurice mentioned, I came from a relatively small country right from the center of Europe, and I live in this city, in Budapest, which is one of the most beautiful cities of the country, and this is an iconic landmark. And I'm pretty lucky that my office is right here in this building. In my office, I have 5 dentists working for me, or I would say working with me. So I'm lucky that I can focus on just those topics I really love to deal with. These are smile makeovers, full mouth reconstructions, implant placements, and of course, their combinations. The today's topic is my favorite. My approach is the tissue-responsible dentistry. It refers to implant placements, but we must understand that responsibility means we should be responsible in restorative procedures as well, like micropreps, adhesive cemented, BPRs, and so on. So when speaking about responsibility, you may ask, what do I mean by that? In dentistry, we should understand science and biology. We should be evidence-based. We should follow minimally invasive procedures. We should serve our patients' best interest. And hopefully, we can impact our patients' life in meaningful ways. As Dr. Brannemark once said, the surgery is not just cutting, but gentle handling of Mother Nature's gifts. And this is my approach, tissue-responsible dentistry. So in this presentation, I'm going to talk about implant placement, especially in the aesthetic zone. I would deal with tissue, soft tissue management in GBR, and of course, the implant-supported restorations as well. But let me start with this case, because I think wise clinicians try to learn from others' mistakes. So as you see on this picture, we have a surgical issue, which is a tissue loss, and of course we have some restorative issues as well. We should distinguish between cemented and screw-retained restorations. And the background of this case, that this was an immediate implant placement some 16 months ago in another office. And the question is always the same. Can we avoid this kind of outcome, and how? And my answer is always the same as well. We should begin with the end in mind, and of course, we have to study the literature. So my personal belief is the rule of the 5 Ps, which is proper planning prevents poor performance. I consider implant dentistry like a multi-sport. We should be trained in every discipline to reach the finish line. So I'm dealing with single tooth replacements, partial reconstructions with GBRs, and of course full mouth reconstructions with all on 6, 4, or 8 solutions. But we must understand that not only the surgery, but the prosthetic skills will affect the final outcome. But first, we must understand the biology and the compulsory bone resorption after an extraction, especially in the anterior zone. Okay, the bone resorption up to 50% happens in the first year, and 2/3 of the 50% in the first 3 months. So this process is not linear. Considering the integrity of the facial tissue, we know from Dennis Tarnow that there are 3 types of sockets. And the question, when to do what? We have minimal 3 options. We should preserve, Sometimes we have to reconstruct, and the less pleasing when we have to replace the lost tissue. From Daniel Boozer, we know that there are factors that are influencing our procedures. These are the patient, the clinician, the biomaterial, and the treatment approach. Sometimes patient brings risk factors, and the education skill and the experience of the clinician has a great effect of the final outcome. Okay, back to this case. When I saw it first time, I knew what was wrong. Referring to the literature, Uli Grunder has a very nice article on this topic, and the summary of the statement that the buccal side of the implant should be covered, and the bone thickness of 2 or preferably 4 millimeters required to maintain the mucosal margin in a stable manner. We also know that at least 3 millimeters should be kept between 2 implants, and that 2 to 4 millimeters between the implant surface and the buccal plate. Okay, here's a sectional image, and here's a real case with my own repertoire. So I placed a narrow diameter implant, and now you can clearly see that it's not always possible to clear that keep that 4 millimeters. So please remember, the more time you waste, the more tissue will be lost. If we find any correlation between the implant placement and the marginal tissue stability, we should understand that anorganic bone graft reduces the horizontal ridge desorption, and the buccally positioned implants are also associated with marginal tissue loss. And this is the case, and this is the reason in this real case. Now you can see that the position was pretty bad, tilted to the buccal. But from Dennis Tarnow, we know that what is the proper drilling protocol in immediate extraction site implant placement. So first, hit the palatal wall, and just then turn to the proper position, and thus we can keep that 2 to 4 millimeters between the facial tissues. Okay, there are a relationship between the peri-implant tissue stability and the tissue biotype, and literature shows that the tissue grafted cases not lose but sometimes gain volume. So I always apply soft tissue grafting, especially in the anterior zone. So let me show you my first case, which was done in 2009. So it was an immediate flapless approach with proper positioning. And I did an immediate zirconia abutment onto the implant, plus a temporary. The main goal always to reduce the marginal tissue loss, the bone loss. And we have 2 concepts, the one abutment one-time concept, which means that we should place the abutment at the time of the implant surgery, and the second is the disconnection effect. So the frequent disconnection of the prosthetic components can lead to the increased marginal tissue loss. But this concept about when we have to cement the restoration, and actually this is not my approach, because there are possible problems with the cemented solution, and this is the remnant cement. So the question, and the big question for me, is screw retained versus cemented. Today in my practice, I apply more than 95, maybe 98% of my cases are restored with screw retained solutions. But there are 5 tips for better implant restoration given by Spear Education. And this is, do screw retain whenever possible. Keep your margins shallow when you have to cement. Use cement that's easy to remove and it's radiopaque. And take post-op radiographs and make restorations cleansable. So back to this case, This is the temporary and the zirconia abutment, and after an additional 2 months, we go further with the smile design and this wax up. And this is these are the restoration of the store model. One full coverage crown on the implant abutment and Emax veneers. There's a very nice scoring system, which is the pink aesthetic score. It refers how good the implant placement and the restoration was. And the number 1 is the mesial papilla, the distal, the gingival zenith, the gingival contour, the alveolar process, and the tissue color and the tissue texture. So let's check it in this specific case. And this is how it looks after 6 or, let's say, 8 months follow-up. And this is the implant. In the last week, I had a chance to take a follow-up image. And now you can see that there was no any significant change of the tissues over the implant. And actually, these 10 years made more changes on me than on the tissue of the, over the implant. So I would, some call it aging, I would say it's tissue maturation. So this is how it looks when she smiles. She had a minor accident on the incisal edge on the right side. But these are the close-up images, side views. But actually, we see some minor recessions around the natural tooth and the veneers. But I'm pretty happy that the tissue stability around the implant is okay. The lateral view, now you can see the tissue profile. It's almost identical with the individual tooth. And this is a quite similar case from 2015. The same procedure, immediate implant placement, proper three-dimensional positioning. And these are the restorations on the store model, veneers in the front, and one implant crown on the implant. And this is the 18 months follow-up. And the close-up image with the tissue level. And now we can see that we didn't lose, but rather gain some tissue on the implant. The close-up image again. And the more closer you look, it was an 18 months follow-up. This is the tissue level, and now we can check the position of the papillae all over. Now I got to a topic which is one of my favorite. This is PET, or partial extraction therapy, or socket shield. Some call it root membrane technique. And I remember the day when this technique was introduced to me. I was traveling and lecturing in South Africa, and one night we had a party together with my friend Harry Gluckman, and at some point he picked up his phone and showed some images on it over this procedure, and I was impressed. And there are some literatures of this topic, of this approach, back to 2010. But this case is really interesting and challenging because, as you see, we have some warning signs, which is this very thin gingival morphotype and the thin cortical plate. You can see recessions all over. And as a recommendation coming from the endodontist, there were 4 teeth needs to be extracted for some reason. And I decided to apply this technique, especially in the anterior zone, because we have very thin tissues. In this close-up image, you can see that we have not more than approximately 1.5 millimeter for both the facial bone plate and the soft tissue. So I left this shield and placed the implant right behind the shield. I'm a big fan of PRF, but I don't want to get into details because after the break, Dr. Shokrum will speak about it. But this technique is not very easy all the time. On the other side, I mean on the left side, I try to do the same procedure. And after the dissection, when I try to remove the palatal part, the facial portion got loose on both teeth. So I had to remove them entirely. But I was lucky that the facial bone was not fractured. It didn't break. So now you can see this was the bone level. And this close-up image is not very clearly visible, but I placed the implants in this position, which is identical with the recommendation that we know from Dr. Tarnu's image. So this is the close-up. This is a narrow diameter implant with 3.5 millimeter. Thus, we can leave a proper space between the implant surface and the bone. But the question for me is always, can this be ever 4 millimeter? Actually, I never found a case with 4 millimeter. So the procedure is the same, sticky bone to fill up the jumping distance. But now we have a very interesting situation. The same patient, same biotype, but on the right side, I could do a socket shield, but on the left side, we are facing with an ordinary extraction site implant placement. So this is the situation after the healing period, and this is the cross-section CT scan images after 6 months. On the left-hand side image, you can see clearly the shield, which protects the facial bone from collapsing. And on the right-hand side, the 2 other teeth without the socket shield. And it was time for taking an impression for the provisional. Now you can see the tissue level. And these are the screw-retained implant crowns, which is my favorite all the time, made of PMMA. And now this is the tissue profile after wearing this temporary for a good couple of weeks. The close-up image, now you can identify some bios particles inside the soft tissue. It never caused any problem. Of course, you can scratch them out from the tissue, but it never caused any problem, especially not for me. So the upper image, the first impression, and the lower image after the tissue molding with the temporary. Now you can see the tissue profile, and we could create very nice papillae between the implants and between the implants and the natural teeth. Can we be satisfied? I think yes. So these are the implants. Here's a nice and pleasing gingival level. But we have a recession on the natural tooth on the left canine. So actually, it's a multidisciplinary treatment with ortho. These are the lateral views. But as a summary, the socket shield is a quite new technique. Long-term success needs to be approved, sometimes challenging, as you could see. So it's not for novice. But when I took this image from the occlusal view, I could realize that there is a discrepancy between the 2 sides. And at that time, I was a bit scared what was going on in the future. So this was the initial situation, and I could see some collapse on the left side. So I would say that PET could keep better the facial bone than without PET. So this is what I did. I decided to protect my facial bone with soft tissue grafting, and I tried to solve the situation in one procedure and cover the root on the left canine as well. So now you can see that it's a very thin gingival morphotype. So I harvested a quite big, giant connective tissue graft from the palate, and applied a combination of two techniques. Mesially, I started with a vista. Vista is, as you know, the vestibular incision, subperiosteal tunnel access, described by Homazadeh first, and ended up on the distal part with an intersulcular tunneling. Thus, I could insert my soft tissue graft, and some literature shows excellent root coverage with vista. And on the other hand, from Preni Plato's article, we know that we can complete the root coverage when we position at least 2 millimeters coronally to the CJ, the new gingival margin. So I did the same. This is the tissue graft. This is right after the operation. Now you can see the new volume. And this is the 7 days healing. This is the same. And this is after 2 weeks before stitch removal. Now you can see on the right-hand side, lower image, that the donor side heals very nicely after 2 weeks. And we have very pleasing, a very large facial tissue volume as well. So now you can see what we gain, at least on the left canine. When we position and pull back the tissue to the proper position, we can reach that at least 2 millimeter coronal position to the CJ. So it's a kind of two-in-one technique. First, I covered the root. Secondly, I protected the cortical plate over the implant with the soft tissue graft. So this case is not fully finished yet, but I think so far it's so good. My second case in this topic is this initial situation. So the left lateral needed to be removed. And we have a kind of classification. It's a colon classification. It's a 3-part code that describes the severity and the position of the defect. I don't want to get into details, but you can check in the literature. So actually, this defect is a vertical, an infrabony defect, but it's a large one. But actually, it's quite easy to augment with GBR. This is the flap closure, and this is what we got after 6 months. I think the result is quite good. So I used his temporary as a surgical guide to place my implant. And of course, I did a large connective tissue graft to increase and boost the biotype, because that's the key for the final restorations. So after 3 months post the implant placement, it was time to take an impression for the temporary. And this is what we got immediately after fixing the screw-retained temporary on the implant. You can see the tissue blanching, but in this occlusal image, and a very nice tissue profile on the left side. And this is the 3 months follow-up after the temporaries. We have very nice filled up papillae between the implant and the natural teeth. This is the occlusal view, nice and thick tissue. So I think it's a quite nice end result, at least with the temporary. So this was the baseline. This is the CT scan image after the GBR and after the implant placement. A bit similar case is my next case. So actually, you may ask, what is the story of this 12 months? So this is the initial situation. We have a CT scan with a clear indication that the patient lost the facial bony tissue entirely. So there was a plan for implant placement, but actually, in my hands, it's not an immediate implant placement, because when we open the flap, it's clearly visible that the complete buccal plate is missing. So some literature suggests that in these cases, we should apply GBR with connective tissue grafting. We should wait at least 7 to 10 months. And from another literature by Daniel Boozer, we have the same recommendations. So I augmented the site, and this is what we got after 8 months of healing. Very nice tissue profile. We have papillae. I could keep it with the temporary, and the flap design does a kind of papilla sparing technique. But the mesiodistal incision line is slightly palatal in order to be able to gain more soft tissue vestibulary, which is almost the same as comes from Daniel Boozer's article. So we could increase the facial soft tissue. And this is the temporary, which is always a must in my cases, especially in the anterior cases, in order to shape, in order to mold the soft tissue. And look at what we got. This is the close-up. It was created just by the temporary. Very nice tissue profile. And now the case is ready for the final restoration, which is a screw-retained zirconia implant crown with a kind of S shape on the facial. And this is the tissue profile from an occlusal view. Now you can see it's clearly almost exactly identical, but when you place your crown, the end result is amazing. I love dealing with soft tissue. So this is just a short summary. And this case is a bit challenging. So this was the initial situation, and the statement is always the same. The facial bone at crest is missing or thinner than 1 millimeter. So it's not easy to deal with such cases like this. But actually did it in 2010. That was a root resorption. And at that time, I was young and brave. So I placed the implant immediately with bone grafting and soft tissue grafting. And actually, they helped a lot. This is what we got after 6 months follow-up of implant placement. Now you can check the tissue level, and this is the 5 years recall. Actually placed a veneer on the left central as well, but my prep line is just at the level of the CJ because I left this question open to make a root coverage, but the patient was not interested in this procedure. So this is why it looks a little bit strange now. So this is the call-up, the follow-up after 5 years. And this is the initial X-ray taken after the implant placement and the abutment. And now you can see that actually we could get some more tissue around the implant after 5 years. It's very interesting. But sometimes I recommend that it's better to be safe than sorry. So this case is a little bit similar to that one, but actually it's a full mouth reconstruction involving the replacement of this hopeless right central. It's like a blister on the cross-section image of the CT scan, and this is the real situation after the flap elevation. So we have sick tissue, which is very pleasing and good, but the patient has high lip line and high expectations, so I decided to augment the site first and then just put the implant in a later stage, let's say after 6 months. This is the temporary with the slight pontic in order to keep the papillae. And when I raise the flap after 6 months, I find very stable facial plate with some mild bone loss, which is not a big problem. It was a platform switching solution, because the main reason not to lose more bone around the implants. I use the temporary as a surgical guide, so it's a prosthetic-driven implant placement. We have papillae, so we should preserve, we should keep it with the incision line. And this is the proper positioning, so I try to keep at least 3 millimeters from the gingival margin with the implant positioning, and this is the healing abutment, exactly 3 millimeter height. So that was kind of mild bone loss, so I augmented this side with a kind of veneer graft. It's not a big procedure, and very predictable, flap closure. And this is the healing after a couple of months. So it was time for taking an impression for the temporary, which is always screw retained if you could position your implants properly. And I must admit that working with thick biotype is a gift. Sometimes we are lucky that we have congenitally thick tissue, but sometimes we have to boost it, the biotype, with tissue grafting. So these are the restorations on the stone model. And this is the real situation in the mouse. Thick, I would say crispy, soft tissue around the implant. And this is the implant restoration, platform switching. I have two things I would highly recommend. First, don't apply a solution when you have a zirconia abutment inside your, as a connector part, inside your titanium, because it can cause some wear. And the other interesting thing that, according to some studies, the milled and not polished zirconia surface can have significantly better and higher percentage of cell attachment and proliferation. So this is what we were looking for, comparing to the case that I showed you in my preview. Close-up image, the gingival tissue level, the position of the papillae, and this is the implant, and this is the occlusal view. Now you can see that the tissue level is quite pleasing, exactly the same as the natural tooth, but if you compare it to the time when I took the impression, there's a big change. And believe or not, there was no additional tissue grafting, just molding, first with the temporary, and later on with the final restoration. So these are the images after placing the implants all over. So it was a full mouth reconstruction. And first I thought it was a low lip line, but finally it turned out that if the patient is satisfied and happy, she could smile much better. So some call it life-changing dentistry. I don't really like this phrase because it's a little bit commercial, but sometimes we are facing this effect, and I think it's the best gift we could get from the patient. Okay, let me show you my final case. I have 3 minutes, so it's more than enough. I just try to emphasize some facts. Actually, this is the initial situation, so it's a bit challenging smile transformation involving implant placement in the anterior zone. So we could transform the right bicuspid into the canine and so on. So first, I placed my implant with tissue grafting and some kind of bone grafting, as the literature recommends. And a little bit later, I applied tissue molding temporary. And this is the part of the smile design, the wax up. And this is what we got after restoring those anterior teeth and the implant. So these are the cross-section images of the CT scan. That was the initial situation on the left. And this is the 3 years follow-up with the implants in a good position. So I'm pretty happy and hopeful that this case will remain the same over years. So we started from here and ended up here. I think it's quite nice and pleasing, very stable tissue all over. A close-up image comes now. Yeah, this one, and a more closer view. And at this point, I try to remember that we as dentists should not forget about our partners sitting in dental labs, preparing very nice ceramics for us, because the final outcome also actually is determined by the lab technician. We can place implant properly, we can deal with soft tissue properly, but if it's not a teamwork and we don't understand each other, the final outcome won't be the same. So just final thought. Yesterday I turned to 50 and we visited a show in the Caesars Palace. Celine Dion was on stage and she said something that really hit me because I believe in the same. And she said that I'm lucky to be happy and I'm happy to be lucky. And I'm happy to have this profession because I'm very respectful and very passionate about it. And I'm very happy to be here, and thank you and appreciate this opportunity for all of us. And thank you for your kind attention.